Welcome, Tony.
All right. I guess that's my cue when I see my face real big on the screen. All right. Good morning, everybody. Uh, let's see. How do I want to start? So I want to just give you an idea of what my morning has been like. So I teach school in the mornings now. I have 3 young kids. I have a kindergartner and 2 third graders, twins, identical twin boys. So I went from 9 o'clock, being a monitor for a spelling test and helping my daughter with a mandala art project. I don't know if you can see I still have paint on my thumb, the proverbial green thumb. I kill most plants, but I'm okay with painting. So that's where I was until about 10 o'clock, and then I have to, put my tie on and become a lawyer again, and a lawyer who has hopefully things that will be interesting for you to learn about. Also, what might make this unique is that I'm going to do this without PowerPoint slides. I do have 2 slides that I'll bring up later, but for the most part, this is just going to be me rapping to you, and hopefully will sustain your interest. But my task is to talk to you about what's happened in long-term care facilities during COVID-19, and that's really depressing. So I'm going to start with something that's gives you an idea of who I am and what I'm about. I think it's important to establish a sort of foundation so you understand everything that I'm going to give you content-wise. So I grew up in in a family in a little town in Ohio near Cleveland, a little town called Huron, and we didn't have a whole lot of money growing up. And so as a kid, I was super ambitious, and I always thought that making money was sort of the path to happiness, that if I had a lot of money, I wouldn't have many worries. So I kind of aligned my career choices to maximizing my income. I was very self-centered as a kid. So I thought I could become a doctor. Like that seemed like a pretty safe way to have a good career that would give me a lot of money, and was achievable because I got good grades in school. Well, in high school, so I'm sort of set myself up to be pre-med in college, and my senior year of high school, my mom is at a department store, and she's in line, and there's some books there, and she picks up a book called The Terrible Truth About Lawyers. And it was written by a guy named Mark McCormick. And my mom's leafing through the book, and she says, "Oh, I think I'll get this for Tony," because with the idea being that this will reinforce his decision to pursue a career in medicine. Because the premise of this book is that lawyers are conniving and manipulative and power mad and sort of control the world. So she gets me this book. She gives it to me at Christmas. This is, coming up on however decades ago. She gives me the book. I start reading it, and I was immediately hooked and decided to change my career path and move into law. Because all of this stuff with control and power and, sort of importance on world affairs was really attractive to me. So my mom was a little bit upset by that her gift had the opposite effect on me. So I changed my major in college from pre-med biology into pre-law political science. But while I was in college, I had never been more poor in my life, and I think that's true for a lot of us, than when I was in college. I had absolutely no money whatsoever. If my parents sent me a $20 bill in a card, like that made my month. I could make that $20 last a real long time. So I kind of got to the point in college where I realized that making money maybe wasn't correlated with happiness, that there's plenty of ways to fulfill yourself emotionally, psychologically, without a lot of money. So I started to become more interested in what's going on in the world and making the world a better place. like a lot of us, I think, engage that way in college. Um, so I decided that I wasn't going to be a lawyer that tried to manipulate people and make a bunch of money. I was going to be a lawyer that tried to make the world a better place. So I found out about legal services, which, there's a whole network of programs throughout the country that provide essentially free legal services to people who don't have a lot of access to legal resources. And went to law school at Ohio State, as was mentioned in my bio. And then I got the hell out of Ohio because I was really tired of living there. And I moved to the place that I thought was least like Ohio in the country, Las Vegas. So I moved to Vegas. I didn't know anybody there, didn't have a place to stay, but I just, as we used to say when we were kids, we charged it. I just went to Vegas, and I really got lucky. I got a job advocating for people with mental health issues in their state protection and advocacy system. California's protection advocacy system is run by Disability Rights California. So I was in the version of that in Las Vegas, and the work was great. I represented people in mental health facilities who were trying to get out, who were being held involuntarily. So there would be administrative hearings to get them out, and I would represent them at the hearings, advise them as to what their rights were during the hearings, maybe handle appeals if they were necessary. And also we dealt with administration of medication, forcible administration of medication hearings. The work was really good. Turns out I didn't really like living in Las Vegas, so I ended up moving to San Diego and got a job in those senior
Hey, Tony, it looks like we're having a couple audio problems. So I think we might be glitched right now. Thank you for your patience, everyone. Just give us a moment to reconnect. Thank you for your patience, everyone. We're just having a problem with connectivity. Please give us a moment.
Okay, am I back on?
You are. I can see you and hear you again.
Okay.
So I'm going to mute myself, and if you run into problems, I'll jump back in.
Yeah, I'm super sorry. I got a dreaded "your internet is unstable" message, and then all of a sudden I was kicked out. I hope that doesn't happen again. I'm really sorry about that. Okay, so I'm in San Diego. I'm going to nursing homes, and I'm seeing a lot of what I would call unmet need. And it was an obvious need. People saying, "Help!" I mean, could there be a more succinct way of saying I have unmet needs than crying for help? And people telling me, "I want to go home." I heard that a lot. "I want to go home. I want to go home." And I would say, well, what's stopping you? So, but I was there for other purposes. I was there to see clients, usually to write wills or powers of attorney or help them with issues related to security deposits in apartments. My goal wasn't in those situations to change the way care was provided in nursing homes. But I was very concerned about it. So I started to focus more on nursing home related cases, and my boss and I wrote grants and got funding to do a nursing home rights enforcement project, which we started in 2003. I ended up doing that for a few years, and then eventually moved to the Bay Area to get a degree in public policy. And while I was pursuing the degree in the Bay Area, I also started working for California Advocates for Nursing Home Reform. So that's what gets me into long-term care facilities. So I don't have the story like a lot of folks do in this field of my grandmother was in a facility and I saw really bad things happen to her, so I was inspired to sort of pursue this as a career. I just sort of happened into it. I wanted to do good things with my career for other people. That was a priority. Um, and just sort of figured out that this was a place where there was a lot of need. I call this the last frontier of civil rights. For older adults, there's a lack of advocacy, there's a lack of resources, but we're trying to fill that gap, and I think California has some very good programs, and we're ahead of a lot of other states. Okay, so let me tell you real quickly about California Advocates for Nursing Home Reform. There's sort of what issues we cover, and there's three generally. We deal a lot with Medi-Cal for long-term care. So that's California's version of Medicaid is called Medi-Cal for older adults and people with disabilities who don't have a lot of assets. You can qualify for to get your care paid for, and Medi-Cal does pay a significant amount of the nursing home bill throughout the state. We deal a lot with abuse and neglect, unfortunately. The primary service we provide for victims of abuse and neglect, or the family members of victims of abuse and neglect, is we have a lawyer referral service, the only state bar certified lawyer referral service for elder abuse and neglect cases. So we connect people to lawyers that might be able to pursue cases. And then the main thing that we do though is we take complaints. People call us, they email us about unsatisfying occurrences in long-term care. Hopefully we've got some guidance for them on what to do. Occasionally we will take individual cases. We'll get very involved and write letters on people's behalf and advocate on their behalf to improve things. But mostly what we do is we try to give a little bit of guidance and information to empower people to advocate for themselves or for their family members. And then we translate, or we take those concerns that they're expressing to us, and we try to know patterns and deal with systemic problems and take them to a policy resolution. So we deal a lot with the regulatory agencies like the Department of Public Health, the Department of Social Services. We write legislation, we support legislation. Sometimes we oppose legislation that we think is going to be damaging to long-term care consumers. So we're very involved in statewide and to some extent national policymaking related to long-term care. That's Canner. We have a website that's chock full of information related to long-term care concerns. We have about, at this point, 80 or so fact sheets on various concerns related to long-term care. So you can educate yourself on certain things and get better care. I think that's the ultimate goal for all the work that we do, is to get better care for folks who need it. Okay, so that's Canner. Let me segue into my message for today, which is the terrible situation in long-term care facilities in California, especially because of COVID-19. So I had a slide for this. This is my message for you, and it's very depressing. And I apologize. I try not to be a very depressing person, but a lot of times my subject matter is, unfortunately. But I stay upbeat by the fact that we're doing something about it. Okay, here's my message. COVID-19 is the worst thing that has ever happened to long-term care. It's the worst thing that's happened to a lot of people and groups and industries. But for long-term care, it has absolutely been the worst thing that's ever happened. But its tragic consequences were partially, if not predominantly, enabled by systemic failures that have been tolerated by generations of policymakers, regulatory enforcers, and society at large. So long-term care facilities have always sort of been in the shadows of society and dangling, just barely making it, and they just weren't strong enough and prepared enough to deal with what we've got in COVID-19. So let me get into a couple of boring things. Some basic information. So what is long-term care? Long-term care is a continuum from a lot to a little of supports and services for people with disabilities who are unable to meet their basic needs independently. And there's a huge range on long-term care. My father-in-law is 87 years old and lives by himself and functions probably 90% independently, but he does get some long-term care services. He has home delivered meals from a senior center. Me and my partner, we provide him services from time to time, transportation at doctor's appointments. These are things that family members do for one another, and they don't really think of it as being long-term care, but these are services that often fall within the long-term care continuum. Nursing homes are at one end of this continuum, at sort of at the end where there's a lot of services being provided, people with a lot of care needs. Nursing homes are marked predominantly by their 24-hour nursing presence. That's what makes a nursing home, pretty much, is that you got to have a nurse on staff 24 hours a day. In most situations. Assisted living facilities are usually considered a step below nursing homes in terms on the continuum of care. A few, some fewer services, but still quite a bit. Assisted living facilities sometimes have nurses on staff. It's very rare that they have nurses 24 hours a day, and they're not required to have nurses at all. That's just sort of a perk at some facilities that there'll be a nurse on staff or a nurse available to the residents. The funding is very different. Nursing homes are funded almost entirely by government dollars. And this is important to know when we get into the issues like quality of care, because the customer usually doesn't pay for the services or pays a small percentage of the services as a copay. The government is the primary payer for nursing home services. So in a sense, that makes the government more of the customer than the actual customer itself, which is the residents. Assisted living is sort of the opposite. Very little government money supports assisted living facilities. Most of that is private pay. So you have a direct connection between the customer and the payer, usually. And then there's a whole host of patchwork, really. It's not I don't think it's what you would call a system of home care services. So there's in-home supportive services is one of the better known programs. Adult day care centers are part of the home care service network. But what primarily makes up home care services are family members who don't even think of themselves as being long-term care providers, but they often are. The vast majority of long-term care in this country is provided by unpaid family members doing the sorts of things that my partner and I do for her father. Okay, so that's definitions. I want to give you an idea of where we were in 2019, pre-pandemic. Things were not particularly good, but they were, it looks like the Garden of Eden compared to where we are now. So pre-pandemic, we have a government funding system that sort of leans toward institutional placement. As I mentioned, the government pays for most of nursing home services, but not a lot of assisted living and almost no in-home services. So to get government funding for your long-term care, you need to have a lot of need and end up in an institutional setting. Now, the United States and California have gotten better over the last 20 years in balancing the funding towards more in-home care, and things have never been better on that front. But I still think we have a long, long way to go to keep people out of the institutional settings as much as possible, and in home and community-based settings where the care just honestly is typically better than it is in an institutional setting, and the quality of life is a little higher. California was having a lot of trouble with complaints against nursing homes. We've never had more complaints against nursing homes filed in the state than we did in 2019. We're now over 10,000 formal complaints filed against nursing homes in the state every year. That's up from about 5,000 just 6-7 years ago. So we've doubled the number of complaints against nursing homes. And the backlog of state investigations of those complaints is huge. Somewhere in the neighborhood of 15,000 to 20,000 complaints behind, open complaints that still need to be investigated. So sometimes years go by before a complaint gets investigated. And you can imagine that hampers the investigation when witnesses have moved into other jobs, their contact information is no longer available, residents have died, witnesses have died, so it leads to a poor regulatory outcome. The primary problem with nursing homes pre-pandemic was we have a situation where facilities can make more money by violating the rules and the standards of care than they can by following them. And that's just because of our weak enforcement system. If you are able to consistently, chronically understaff your facility and save money on the labor costs, you're going to make more than it's going to ultimately cost you if you have to pay some fines for being chronically, continuously understaffed. It's one of those problems with having a third-party payer system where the government's the payer, and they have a different idea of quality than maybe the residents themselves have. And there's a lot of disconnections between quality of care and profitability. And that's been a problem for a real long time. It just seems to get more and more acute as time goes on. We've had a lot of understaffing in facilities. We've had massive problems with overuse of psychotropic drugs. We've had a lot of problems with evictions and unlawful inappropriate discharges. And what's enabled a lot of these problems has been really very weak enforcement. I'm sorry, there's like a helicopter. It seems like it's directly above my building. I wonder if they're looking for me. I'll just stay inside and won't leave for a while. All right, so now let's move into 2020 with COVID-19. How bad has it been? It's been really bad, folks. And just in California alone, we've had more than 30,000 nursing home residents infected with COVID-19. To give you an idea of the scale, California has about 100,000 nursing home residents at any one time. 30,000 infections since March. Over 5,000 residents have died now. So about 100,000 residents. Now there's been some turnover. So over the last 7-8 months, there's probably been, I'm just gonna guess here, maybe 150,000 total residents that have been in nursing homes. Over 5,000 of them have died from COVID-19. Assisted living facilities have fared better generally. I think there's a lot of reasons for that. I mean, just again, not knowing anything else, if you're comparing assisted living to nursing homes, in my experience, assisted living is just going to have slightly better quality of life, slightly better care, and they're smaller. There's a lot of really small assisted living facilities, so there's not the same risk exposure in assisted living, but still there's been over 12,000 infections. There's about 140,000 assisted living residents in California. We've had 12,000 in COVID-19 infections and over 1,200 deaths. Now the death count includes staff members as well, so I don't know exactly how many residents, but probably the vast majority of the deaths in assisted living have been from residents and not the staff. Why has it been so bad in nursing homes? I think you can guess, and I think anybody could guess as to why. You've got usually very frail, infirm residents who, with a lot of what doctors call comorbidities, other conditions that make them weak. Their infection system or their immune system's weaker, and they're just going to have worse outcomes if they get COVID-19. There's a lot of people crammed, and especially in nursing homes, there's a lot of people crammed together. The average nursing home has most people, 2 to a room. Some nursing homes have people 3 or 4 to a room, and they're being cared for by the same group of people day in and day out. So there's, and they require lots of face-to-face care. There's just no way that you can stay 6 feet away from someone who needs a lot of long-term care. You have to turn them, you have to feed them, you have to bathe them, you have to groom them. There's all sorts of needs there that it's very hands-on. So you have staff people who come into one room and deal with one resident, and then they go deal with 10, 11, 12 other residents each shift. So there's a lot of mixing. Another problem is that nursing homes have been historically really, really bad at infection control. I want to tell you that the CDC on its website cites a study from 2004 that estimated that over 388,000, let me say that again, 388,000 long-term care facility residents died each year from preventable infections. So all things considered, COVID is, I mean, it's kind of business as usual in nursing homes in terms of really bad outcomes from infection. Now, I know there's a lot of huge distinctions with COVID-19, but from the perspective of mortality and rates of infection, COVID-19 it's just more of the same that we've had. We've had a lot of people die every year from preventable infections in nursing homes, and there's been a lot of media attention on this fact. Infection control problems are the most cited deficiency in nursing homes throughout the country, year in and year out. So the biggest problem when state investigators go into nursing homes to see whether the care being provided is good or bad, the number one citation in all of these investigations has been historically infection control. So it's been a problem for a real long time. What we've seen in the work that we've done at Cantor, we took a look at the 25 worst nursing home outbreaks of COVID-19. This was as of mid-August or so. And we found that past performance does indeed indicate current results. So facilities that had the worst outbreaks had star rating averages. So the federal government maintains a database of a 5-star rating system for nursing homes. It's called Nursing Home Compare. The 5-star rating system weighs nursing homes on a bunch of different measures, and the average in California for the 5-star rating system is at 3.5. So the average nursing home has a 3.5 star rating. In the facilities with the 25 worst outbreaks, it was 1.68, so less than half the star rating. The facilities with the worst outbreaks had more infection control violations in years past, significantly higher infection control problems than they did in the past, than facilities that didn't have as big outbreaks. They also had less staffing. I don't think that's much of a surprise. 7% less direct care staffing and 39% less registered nurse staffing than the average nursing home in California. So these facilities that have had the worst outbreaks were sort of primed to have the worst outbreaks because they don't provide the same quality of care as most nursing homes in the state. So this just demonstrates that there's a connection here. The facilities that have records of doing poorly on lots of things, including infection control, had worse outcomes related to COVID-19 than facilities that have better track records. Okay, so the care historically has been bad in nursing homes. That's part A. Part B is the enforcement the enforcement of our standards, our regulatory standards, has been very bad as well. California actually has really good nursing home standards related to quality of care. The problem has always been just making sure that they're actually operationalized in the facilities themselves. So a couple things that went wrong in California from the outset of COVID-19. Transparency was a problem. When the first hotspot for COVID-19 in the country was a nursing home in Washington called Kirkland, Life Care Center of Kirkland. And then we started to hear about facilities in California getting COVID-19. And we thought it was important for the Department of Public Health, the agency that supervises nursing homes in California, to tell the public which nursing homes had COVID-19, because that would be a really important decision point for people who are making decisions about where their loved ones were going to go for their care after a hospitalization. California initially balked, a lot of states initially balked, and the federal government balked on providing transparency as to which facilities in California had COVID-19 outbreaks. So it was about 3-4 weeks into the game before we actually started getting publicly available information about which facilities had COVID-19. I thought that was a significant misstep. An ongoing problem in California and in lots of other states, I don't want to single out California here, has been a lack of coordinated leadership on things like COVID-19 testing. There's just been holes in the way facilities can test staff or residents, and there's never been an effort to make sure that there was coordination statewide as to how the testing was going to be provided, who was going to pay for it, and how often it was going to be provided. One of the big missteps in this has been a blanket ban on visitation in long-term care facilities. Now, in the early days of the pandemic, when everybody was really scared and didn't know what to do, the visitation ban made some sense. Like, let's isolate these facilities as much as possible, minimize the risk exposure of the residents, because this can be a very terrible thing when it gets in. But what happened as the days turned into weeks and the weeks turned into months was people started declining from the isolation that was imposed on them from the visitation ban. And the visitation ban was more than just something that had a bad emotional outcome for residents. Psychologically, they're missing their family members, not seeing them and not having interactions with them. But they were also deprived of a really rich source of care for them. I never had an appreciation until this year how much care that family members actually provide in facilities. So I mean, we think of facilities are full of professional caregivers and they're doing all the work that's necessary. Family members will tell you that they have, for the most part, provided supplemental care in the facilities. And a lot of times it's the stuff that staff members just don't have a lot of time to do. It's things that require a lot of patience, particularly focused on feeding residents who have trouble swallowing and trouble handling the silverware themselves. So family members, and it's actually bringing in food that the resident likes, as opposed to the stuff that's made in the facilities. So because we have family members being locked out of the facilities, the residents are being deprived of a lot of care that they normally get, and they're being deprived of this sort of emotional support system. So they're just declining really badly. Now, California has been among the national leaders in pushing for more visitation, but there's been lots of problems operationalizing it. Every local community has its own rules, and they are overruling the state's rules related to visitation. So even though the state has pushed for outdoor visitation, for example, and in some cases indoor visitation, family members are still being locked out under the guidance of local public health authorities. And there's not been a lot of coordination there, and it's been really sad. I can't tell you how many people we've heard from just at their emotional end, at the inability to see their loved ones and to provide the care that they know that they need. And they're in this enormous, unwinnable dilemma of leaving their family members in facilities where they can't oversee the care. They suspect that there's neglect and isolation going on, but they themselves cannot bring them home and provide the care that they need. So it's damned if you do and damned if you don't. California has also under-enforced our infection control requirements during the pandemic. One of the first things the government did was decide to stop doing their regular routine inspections and just do infection control inspections. So all they're going to do is go into facilities and focus on the infection control, nothing else, which I think makes some sense, at least initially in the pandemic. But they issued no enforcement actions. They did over 1,000 infection control focused surveys in April, May, and found no violations, which seems kind of incredible given the fact that we've had so many enormous outbreaks in nursing homes. So I want to let you know just sort of how California is doing as compared to other states. In California, just generally, among the general population, we've had 31 cases of COVID-19 for every 1,000 Californians. 31 for every 1,000. In nursing homes, that number is 289. So in nursing homes, 289 out of every 1,000 residents has been infected with COVID-19. That is a startling number to me, and an order of 10 times higher almost than the general population. In California, there's been 0.5 deaths per 1,000 people. So you got to get to 2,000 people before you would find one death. In nursing homes, it's 54 deaths for every 1,000 residents. So now we're talking 108 times the number for California in general. just enormous, enormous problems. And what this doesn't capture is maybe even a more alarming statistic if we could put it together, which is the number of deaths that were caused by neglect or isolation, or the profound negative impacts of all the isolation from COVID-19. So I've heard from some family members that say, in some cases, we're protecting the residents to death by depriving them of the family members that provide them so much support. We've heard a number of cases about weight loss and depression and all sorts of really bad things going on. Okay, so here's where I want to show you 2 slides. I'm going to go to share my screen here, and hopefully this will work. And I'm sorry for all the depressing news. I wish I had more to report. I will end on a note of what we can do now. So let me see if I can start the slideshow. Okay, so I just want to give you an example of what's going on in California. This is on the right-hand side, you'll see a deficiency that was issued in June against a facility called Magnolia Rehab, which is in Riverside. Magnolia Rehab was in the news in April, I think it was April, it might have been May, for having to evacuate all the residents because there was a huge COVID-19 outbreak that included the staff, and the facility just didn't have enough staff to take care of the residents, so they had to be scattered to different facilities and hospitals throughout Riverside County. And you can see on the right-hand side, in the summary, there's discussion about staffing shortages and all sorts of problems. Now, these were interviews done in June, but they're talking about the situation back in April. So it was April when this place was evacuated. What you see on the left-hand side is this is an infection control focused survey that was done, and you'll see the date. I'm going to put my cursor on it. Hopefully you can see it. April 7th, 2020. Okay, this is April 7th. The state government went in and did an infection control survey. And at the bottom, you'll see no deficiencies were issued for the COVID-19 focused survey. So they found no problems as it relates to infection control, at least nothing worth writing home about. And then this is April 8th. The very next day, the facility had to be evacuated, all 83 residents evacuated, after they were given a clean bill of health by our State Department of Public Health just the day before. So the reason I show you these slides is to get you really pissed off about the oversight that was being provided to nursing homes at this very critical time in our state's history, where we've got surveyors going in and basically patting providers on the back instead of finding problems that obviously existed at the time that they were there. Okay. So I'm going to stop my screen share and go back to, maybe you'll just be seeing my huge face again. Okay, so some positive things. Not a lot, but transparency is good now. There's transparency at the federal level related to nursing home, the situation in nursing homes, and at the state level, nursing homes and assisted living facilities. We have regulatory agencies have websites where you can see data on which facilities have outbreaks, for the most part, the extent of the outbreaks, the number of deaths that have happened in those facilities. So we're able to keep much better tabs on where there may be trouble in particular facilities than we did at the beginning of the pandemic. So that's a positive development. PPE is holding. California has done better than I think a lot of other states related to making sure that the healthcare providers, the frontline workers in these facilities have PPE. I've not had any reports of shortages in many, many months. The ombudsman, the long-term care ombudsman, I think we may have some ombudsmen in this out there listening right now. They are what I would call backish into facilities. They were also excluded from facilities as part of this visitation ban and spent several months on the sidelines, not able to go into facilities, which I think was a real problem for a lot of, alarming for a lot of reasons, but they are now able to go back in. I'm still not sure exactly the circumstances, but I'm hearing from ombudsmen that they're going back in and see things for themselves. I don't think a lot of the volunteers are excited about going back in, but some of them are going back in, and a lot of the staff are going back in. We've learned a lot. Nursing homes, assisted living facilities have learned a lot. I think the regulators have learned a lot. There are now mitigation plans in every facility that I think are, heads and just significantly better than what we had prior to the pandemic in terms of how to handle an infectious outbreak. We've learned a lot about cohorting. We have now red zones and yellow zones and green zones in facilities. I just think that we're doing a much better job when COVID-19 is actually in a facility and isolating it and protecting the residents as much as possible. I think that's improved a lot since the pandemic started. Things that we could still be doing better on, I think, are obviously the visitation. I have a lot of problems with the way visitation has been handled, especially at the local level. I think the main problem at the local level is we have people who never set foot in nursing homes and don't understand the long-term care environment, making decisions about whether people can go in and out. And I think the local public health authorities are entirely focused on outbreak rates and not so much on the other issues of well-being in long-term care facilities. We've had a lot of concerns about coming and going, especially now it's the holiday season. We were concerned about residents going out for Thanksgiving with their family members and then being told that they can't come back in to the facility. We have had a number of reports of facilities telling residents that once you've gone out, you can't come back in. In some cases, the best case scenario is that they come back in, but they're subjected to a 14-day quarantine. That can be pretty harsh. So that's been a problem. A couple other things I want to talk about, but I'm not going to do that in the interest of time. So there's obviously a lot of concerns with what's going on in long-term care facilities. What can we do? I feel terrible saying this, but I think other much more famous people have said it. You don't ever want to waste a good crisis. The COVID-19 has exposed lots of systemic problems in nursing homes and made them much more obviously lethal. And it's time for us as a state, as a country, to sort of reckon with long-term care. Is this the best that we could be doing? I think the obvious answer is no. We could be doing a much better job. And it starts with keeping people out of facilities in the first place, long-term care facilities. Keeping them home as long as possible, giving them the services and supports they need to stay at home as much as possible, which is most people's preferences. So, the funding, the way we fund long-term care, I still think we have this institutional bias that we need to get away from. I think we need to rethink the physical structures of long-term care facilities. That, bigger isn't always better. I think in most cases, bigger is not better. If we can keep our nursing homes, especially, or other facilities, more home-like, and to be more home-like, you usually got to be smaller. It's hard to be home-like when you got 200 people in the building. So smaller home-like settings, and there's been a lot of discussion about that in the media, that what alternatives look like. I think we could do a much better job aligning our spending, our government spending, on quality. As I said before, it doesn't matter much in terms of quality. The worst facilities in California get about the same revenue as the best facilities in California. I think that's a really bad incentive structure. There's not a whole lot of incentive to do better. The facilities that do better, it's usually just because they have a good culture as opposed to profit motive.
Tony, we've got a couple questions coming in. Do you have a moment for some questions?
Yeah. Okay, let's do that now.
Okay. I think you're on a roll here, and I think you might be able to answer these very well. One of the questions we came up is there no monetary penalty for nursing home residents that contact a preventable disease, even after inspection?
The question, is there a penalty on the resident?
On the nursing home facility.
Okay, so is there a penalty on the facility when?
When someone contacts a preventable disease? Are they fined?
Oh, no, no. So just, I mean, the fact that somebody got an infection, that's not a deficient practice in and of itself. Again, just sort of the way you got multiple caregivers with multiple residents and a lot of cross-pollination, so to speak, you're going to get infections. And I think that's sort of understood. But there's obviously standards. For example, this was a problem, at least early in the pandemic, with some of the infection control surveys. What they found was staff members still weren't washing their hands after providing care to one resident and then going to take care of another resident. So they were taking care of one resident hands-on and then going to another resident and providing care hands-on without washing their hands in between. That's a pretty significant, serious violation, and that would be citable. But then there's a difference between citing a deficient practice and actually imposing a financial fine. And one of the problems in California and throughout the country is that when surveyors find deficient practice, like not washing your hands, it's not accompanied by a financial fine. Very rarely. It's probably somewhere in the order of 10% or fewer of identified deficient practices actually end up in a fine. And then another problem is if there is a fine, it's usually very small. So it doesn't, what happens here is you learn this fine is worth it. If the worst outcome for me is a $2,000 fine, then it's worth it to me to save tens of thousands of dollars to not have enough staff that feel hurried enough to not have time to wash their hands in between care. So I can make more money by having fewer staff who hurry and rush and don't wash their hands and just pay the $2,000 fine.
Okay, we've got a couple more coming in for you. Do you think private Medi-Mal lawsuits in the long-term care space can help bring attention and positive change to the industry?
Yeah, I do think that. I think that lawsuits play a really important role in the enforcement system that we have. I think it actually in California probably plays a disproportionate role because the litigators who take these cases are sort of filling a void of enforcement that occurs at the state regulatory level. So yeah, I think lawsuits can have an impact. I mean, we certainly hear from facilities all the time that they're concerned about getting sued and that affects the way they practice, and it should. And the idea of immunity being provided to healthcare providers during COVID-19 that's come up in a lot of states, including California. A lot of states have passed legislation to immunize healthcare providers related to any negligent decisions made during the pandemic. California has not adopted immunity, so we've kept that idea of accountability. I think that important idea of accountability in California, that if you act unreasonably and people suffer and get hurt as a result of that, then you can still be held liable. And I think that's important.
All right, I've got one more. How have California's 6-bed facilities fared compared to the bigger and more traditional nursing home facilities with respect to COVID-19, infection rate, death rate, PPE, et cetera?
Yeah, so I think that question's really getting at, so there's two kinds of assisted living facilities in California, really. There's the small 6 beds or fewer, so you got 6 residents living in a single family dwelling, and you have the large buildings that look kind of like nursing homes or apartment buildings, senior living centers with up to 100 or 200 residents. How have they fared compared to one another? I don't have the data on that, but I think the last I've heard is that the smaller facilities are just generally doing better. And I think the main reason obviously is minimized exposure. A lot of times it's just 1 or 2 staff people in those 6-bed facilities. There's going to be the same 1, 2, or 3 caregivers every day, as opposed to a nursing home, or a larger assisted living facility where you're going to have dozens, maybe scores of staff people coming in. And we've known from pretty early on in the pandemic that the source of COVID-19 infections in these facilities are staff members. So the fewer staff members you have, the less exposure you have. I also think that 6-bed facilities have done a little better because of fewer residents. The residents there's just less exposure from resident to resident when you've got 6 people as opposed to 100 people in the same building. One data point that I've heard as it relates to assisted living is dementia care. There was a survey done by the state government, and they said that there's about twice as many COVID-19 cases in assisted living facilities that have dementia care units than those that don't, or in the dementia care units than in the non-dementia care units. So this would be what's called memory care. And I think the hypothesis is that because memory care residents with dementia are much less amenable to keeping their masks on. So there's higher risk of spread in those facilities, but that was a relatively informal survey. I haven't seen any real hard data.
Okay. Well, thank you, Tony, for sharing your personal journey of how you've got involved in the aging services and how much it's meant to you. It is my pleasure to now introduce you to our last speaker today, Dr. James A. McKinnell. Dr. McKinnell is an infectious disease specialist with specific research interests related to clinical management and prevention of healthcare-associated infections. He has published over 40 papers, many focusing on optimal uses of antibiotics and how we can better understand antimicrobial resistance in our communities. Dr. McKinnell has worked with skilled